Thank you so much for the very kind invitation to come and talk at this meeting. And the talks so far have been extremely impressive. And we're moving from the very important clinical arena from this morning, and then Doug's talk about the law, and we're moving more towards the research arena, which sets the scene for Anne and Bernard's talk this afternoon about what we're trying to do to try and find treatments, disease-modifying treatments that may help Huntington's disease. So I'm going to tell you a little bit about our work and our research that moving towards this goal. So we know this is the HD mutation, and here in the first exon is where the mutation is and all the damage. It's a huge gene, 67 exons. And importantly, Huntington, the protein, very large protein, 350 kilodaltons, huge protein, is expressed throughout the body. It's not just a protein that's expressed in the brain. Every tissue that's been looked at expresses wild type and mutant Huntington. We know it has a very important role. If you knock it out in embryogenesis or in embryos, the embryos die. Huntington's disease is not just a disease of the basal ganglia or the striatum. It's a disease of the cortex. It's also a disease of the body. And a loss of the functional structural connectivity between the cortex and the striatum, this part here in the striatum, plays a major role in the disease symptomatology. It's loss of that connectivity that we're trying to interrogate and understand. And Huntington's disease is more than a disease of the brain. Many of you who look after patients are very aware that weight loss is part of the disease, muscle wasting occurs, and many different features occur: digestive tract, endocrine abnormalities, immune dysfunction, which we have a big role in, a big research program in looking at how the immune system modifies the disease. And this is a lady from Venezuela from 1985, and this is the lady 13 years later, cachectic. Luckily, in this country, we're able to manage many of these aspects of the disease with high caloric intake and assisted feeding. But Huntington's disease is what we call a procatabolic condition, in that muscle wasting and weight loss occurs as part of the disease. It's not just related to the difficulty swallowing. So in Huntington's disease, we're all working towards trying to find disease-modifying therapies. I think, being a person who works in HD, sees patients, I feel very strongly that I have to do research as well, because I have to be working towards trying to find treatments for this disease. And we have an advantage in Huntington's disease in that we can exploit the genetic certainty of this disorder to help understand the whole preclinical phase of neurodegeneration. And many of you will have seen these slides before, and I'll just run through because it sets the scene for what I'm going to tell you about. You're born with the mutant gene, you're completely well, until some point the nerve cells in your brain start dysfunctioning. Later on, they start dying, and symptom onset occurs at some point in this trajectory. We want to understand this whole period of nerve cell dysfunction in more detail, because nerve cell dysfunction is potentially reversible. Lots of data in mouse models have shown that if you switch off the mutant gene in adulthood, many of the nerve cells recover, and that's potentially reversible. And because we have a genetic test and we can identify people many years before they develop symptoms, we can understand the way the brain is changing before symptom onset and in the early phase of the disease, which is going to be critical for therapies. And eventually, we want to be able to intervene many years before symptom onset to delay symptom onset or disease onset into old age and beyond. So this is a great goal that we're all working towards. And in HD, we're able to do that. In Alzheimer's disease and Parkinson's disease, by the time a person presents, this phase of the disease has been going on for many years, and it's relatively poorly understood. But in Huntington's disease, we can really interrogate this such that we're going to be able to intervene with therapy trials in this phase. So I'm going to tell you a bit about TRACK-HD, which is really trying to help this process. This is a multi-center, multinational study trying to understand the neurobiology of the pre-manifest and early phase of the disease, to identify predictors of onset and modifiers of progression. We know that progression is dependent on much more than the CAG repeat of the mutant gene, and we want to try and identify what modifies it. We want to determine the measures that are most sensitive for detecting change in pre-manifest and early HD, because that's going to be essential, absolutely critical, to undertake future clinical trials of disease-modifying agents. If we don't have this, we can't do this. So I'm not going to, many of you will know about TRACK-HD, so I'm going to give a brief overview. It's a multi-center study. We run it according to GCP standards, which means we run it like a clinical trial. Many of you who know about or are involved in it know about the rigor of the study. We have rapid blinded data quality control. We have regular on-site data monitoring. And importantly, we have a statistical analysis plan that's predefined. And we have an independent team of statisticians who do all the work. It's not undertaken by the investigators. So it's an independent stats team, which I think is very important in these sorts of studies, because often researchers will have a vested interest in their own data looking good. This is a completely independent stats team who do all our analysis for us. So this is an overview, 4 study sites: London, Leiden, Paris, and Vancouver, 123 controls, 120 people who are pre-manifest, who've been divided into 2 groups, 62 who are what we call pre-A, who were greater than 10 years to predicted onset based on the Langben equation at the time of recruitment, and pre-B, who were less than 10.8 years to predicted onset based on the Langben equation. So pre-B are essentially nearer to onset, pre-A further from onset. And 123 people with early stage disease, 77 stage 1, 46 stage 2. We've been doing 3T MRI, DTI, PET, and MRS studies, a number of quantitative motor tasks, cognitive testing, eye movements, neuropsychiatry, wet biomarkers, and genetic studies. And I'm going to really give you an overview of what we've done and where we are and where we're going. We published the baseline paper in September 2009, and that's open access, available for anyone to download. What we found, and this has been found in a number of other studies, is that there were many changes in the brain in all of our groups, from the pre-A group, the pre-B group, stage 1 and stage 2. This is the controls. From the earliest onset, the pre-A group, they were different from controls. But this is cross-sectional data, so it's taking a single cross-sectional time point and looking at the differences. And it's not surprising we saw so many changes, because this represents about 25 years of a neurodegenerative process. This was a single time point, a cross-sectional time point. But what we knew is that the pre-manifest A group were not the same as controls, even in that cross-sectional time point. We also found many changes in thinking cross-sectionally in all the groups, but the pre-A group, in terms of their thinking tests, performed very similarly to the controls in the cross-sectional analysis. These are some of our tasks. This is emotion recognition, and this is spot the change. And then we also found large cross-sectional differences in motor function, particularly in the early stage and pre-B group compared to controls, and in eye movements. But as I said, that's a single time point, it's cross-sectional, and it represents a large spectrum of disease. We published a number of cross-sectional papers describing the data, and Rachel Skyhill, who's here in the audience, has been really pivotal in a lot of the data I'm going to show you. And she leads our HD team, the imaging team, based with us at the National Hospital Institute Neurology. In January in 2011, we published the first one-year paper. And this is where it becomes important and more interesting, because this was publishing, and this was showing change. Cross-sectional data is relatively easy to collect, but it's showing that how things change over time that's very important, particularly if we want to try and identify measures for therapy trials. And this is a brain scan of someone who's a pre-manifest A subject. This person is 16 years from their predicted disease onset. This is the baseline scan. That's their 1-year scan. And if I flick between the two, you can see they've been registered against each other, so they match very closely. You can see the change over just 1 year, someone 16 years from onset. And this is using very sophisticated measures, defining very small amounts of change. But you can see here in red, if you're able to see that, the area of tissue loss, as you can see, around the caudate. But it allowed us to start developing measures that over a relatively short period of time, we could produce what we call metrics to measure change. And what we found, over just 12 months, there was significant global in whole brain and regional in the striatum, caudate, and putamen, changes in pre-manifest and early HD, it's a really short time period. You've got to remember people will have 20, 30, 40 years of a pre-manifest phase of the disease, and then the early phase of the disease may be up to 6 to 8 years. So over just 1 year, using some very sophisticated brain measures, we were able to see change. And I think that was the most important finding that came out of this, suggesting that we could even test therapies over a 1-year period in certain groups. And I think the next piece of work, which I think really begins to start putting some more flesh on this, was the paper we published recently on the 24-month data. And this has really given a number of insights. So what we found over 24 months is there were significant changes in the whole brain. So the whole brain, similarly, as we were seeing over 1 year, the whole brains in early stage HD and pre-manifest HD were changing compared to controls. We found it over 12 months and we found it over 24 months. And these are the plots. This is the baseline, 12 months and 24 months. This is the controls. As all controls lose brain volume. That's part of the aging process. And that's why it's important to have a control group. So the controls are losing brain volume. But you can see here the pre-B subjects over 24 months losing brain volume in stage 1 and stage 2. The pre-A, in terms of the whole brain atrophy, actually are doing pretty well over 12 and 24 months. This is the caudate. This is where the disease really, a lot of the theories about where the disease begins. It's a subject of a whole talk. But the caudate is where you can detect the very earliest abnormalities, and it's where we detect the most significant change. And over 24 months, all the groups showed significant change compared to controls. This is the control group. Pre-A, greater than 10.8 years to predicted onset. The pre-B, less than 10.8. And you can see here, highly significant changes in caudate volume loss over 24 months. And this is here shown, and I'm going to show you a film of this. Grey matter, this is a way of quantifying the grey matter in the brain and the cortex and the striatum. This is the pre-A group, the pre-B group, the stage 1 and stage 2, and we can quantify this. And we found by quantifying the grey matter in stage 1 and stage 2 and in the pre-B, we could quantify significant grey matter loss around the striatum, but also some in the posterior cortex. But importantly, and I think this is one of the important things that's come out of Track HD in terms of the imaging, is the very striking white matter loss. Now, white matter is the connections between different parts of the brain, and in diseases such as multiple sclerosis, white matter is where the disease really occurs. You get loss of myelin. HD has never really been thought of as a disease of white matter, but using these measures, it's very clear that white matter is lost, and lost significantly. And that's what I meant when I said I think the loss of structural and functional connectivity between different parts of the brain is actually underlying the symptoms in this disease. And we need to really understand this in terms of finding therapies. So for example, if you were going to switch off the abnormal gene using gene silencing, which I'm sure Bernard will talk about, we also want to think about ways we're going to support the nerve cells recovering, what we call neurotrophic support, because they have to recover these connections. And that may be something that Anne will cover in her talk on transplantation. So this is the pre-A group, pre-B, stage 1 and stage 2, and this is the quantified white matter change over a 24-month period. And you can see here in the pre-B group, just over 24 months, this is the amount of white matter they're losing. And you can see it's the connections between the deeper parts of the brain and the cortex. So it's that loss of connections. And this is it, quantified, highly significant changes from pre-B, stage 1 and stage 2. So we know the brain is changing many years before symptom onset, and we're being able to really model that. And it's important that we're doing that because we want to be able to use that information to test therapies. What we've also found, importantly, alongside the brain changes, in early stage HD, in the measures of cognition, which is thinking tests, motor tests, we found consistent change in early stage HD in many of the non-imaging variables. And this is, again, the controls, pre-A, pre-B, stage 1 and stage 2. This is the symbol digit. The symbol digit's been around a long time. This is a test of attention and concentration and also psychomotor function, how fast you can write. And this task has performed very, very well. And we found consistent change in stage 1 and stage 2. This is a tapping task, and this is a circle tracing task, which is very much a bit like driving. You have to keep your eyes on the road and turn a steering wheel, etc., move your feet. And this is very similar to that task of trying to drive. And you can see over a 2-year period, stage 1 and stage 2 subjects deteriorate compared to controls. But what you may have noticed in these graphs is that the pre-manifest subjects overall over a 2-year period are not deteriorating significantly compared to the controls. And I'm going to come back to that. So for clinical trials in early stage HD, stage 1, stage 2, stage 1 and stage 2, and particularly stage 1 are going to be the groups of people who are going to have many of the novel disease-modifying therapies first. And there's a lot to rescue functionally in that stage of the disease. Many of you who are very familiar with the staging. We now have potential outcome measures to do disease-modifying trials in early stage HD over 24 months. It's a huge step forward. And these are well-powered outcome measures for these trials. And based on the outcome measures we have, we can do sample size calculations. And sample size calculations are very important if you're trying to see how well-powered your trial is. And I'm going to show you something that I think is sobering when you think of all the trials that have been done to date in HD and why we, so far, I think it's a combination that we haven't possibly got the best drugs so far, but there's a lot of exciting things in the pipeline. But also, if you look at this, so the caudate atrophy, we showed an effect size, which is how the magnitude of this change compared to a control group of nearly 2 in stage 1 subjects. That's a large effect size. And you can see here, using caudate atrophy as an outcome measure for a trial, if your treatment was anything better than 20% effective, 40, 60, 80, 100% effective at slowing the disease, you need a very small number of people in each arm. You can see here, 30 to 40 people in each arm. If your treatment is even 20% effective at slowing the disease using caudate atrophy over 24 months as an outcome, you still need about 180 people in each arm. But if you look here, this is the total functional capacity, very similar effect size to the total motor score. Here is its effect size. If your treatment is 40% or better at slowing the disease, you can get away with just under 200 people in each arm. But every therapy that's been tested to date has not been predicted to be better than 40% or better at slowing the disease. That's a big change. So if it, at best, was going to be effective at slowing the disease by 20%, you need 640 people in each arm. That's each arm of the trial to be powered properly. And I think this tells you using these very careful measures, is that we really need to power our studies properly to get the right outcome. If we don't design the studies properly, and if we don't power them properly with the correct sample size, the study is not worth doing. And I think this tells you the TFC and the TMS, many of the studies done to date have not been powered to detect other than very effective disease slowing. And I think this is sobering. So one of the things that people often ask is that you find all these brain changes, what does it mean? And that's something that we're very much focused on now. How can we understand how the brain changes contribute to the disease onset and progression? And I think it's really important. So atrophy is the first reliable change that we can see over everything in HD expansion carriers. So is it just a morphological observation, or does it mean something functionally? So what we asked was this question. So we took all our pre-manifest HD subjects in TRACK-HD, and we divided them into those who progressed and those who didn't progress, very simply, and asked what was the difference between the two groups. And it's very interesting, because what dictated more than anything whether you progressed if you were a pre-manifest gene carrier was the change over 24 months in your caudate volume and the change in your white matter. So those who had the most significant change in their white matter and those who had the most significant change in their caudate volume progressed. Whole brain atrophy was associated, but less so. So what we are showing is that the brain changes that we're detecting actually mean something. So we can actually now stratify subjects based on the way the brain is changing. We can try and make predictions about disease progression. So the pre-manifest subjects who progressed had higher rates of regional and white matter atrophy. And I think that's telling us that the brain changes we're detecting are associated with something very fundamental about the disease process. So I'm going to show you just some hot off the press 36-month data. So the 36-month timeline finished in November. We just got all the data very recently. We're still analyzing it, but there's lots to do. It's a huge amount of data. We've got over 1 million data points. But I think the main take-home message from the new unpublished data is that now in the pre-B group, we have many non-imaging measures that show significant change. So we know that we could do good disease-modifying, potential disease-modifying clinical trials in early stage HD over 24 months, well-powered, good sample size calculations. The data we have now suggests that we can do good disease-modifying, potential disease-modifying clinical trials in the pre-manifest B group over 36 months. And that's a big step forward, because if any regulatory authority is going to allow us to do potential therapy trials in people who carry the gene but are completely well, we have to be able to convince them we have ways of measuring progression, because as many of us here and those of us who took the Hippocratic Oath, you first must do no harm. You have to be very sure that you have good ways of measuring progression before you start intervening in people who are pre-manifest gene carriers. So this is a film that we've made. It's based on real data that I've made with Rachel and Ed Wild. And this is a brain scan of someone with early stage disease, and we've matched it very, very carefully, and we've turned it into a video. And this is how the brain is changing over 36 months. And if you watch carefully, you can see here the caudate is shrinking. In green, the cortex is shrinking here. And in yellow, the ventricles are expanding. I've got it on a loop, and I'll show you it again. So you just have to watch carefully. This is the ventricles expanding. And here in green, you can see the cortex shrinking. And this has been over 36 months. So this is how the brain is changing in early stage HD. And here, I'm going to show you another section. If you watch here, this is the caudate. And you can see here, the caudate, if I can, oh, can you get that one to start? Sorry. There you go. So you can see here, the caudate is shrinking down. This is real data, 0, 12, 24, and 36-month data. And you can just watch. If you just watch the caudate, you can see it change. And that's real change over 36 months. The green is where the cortex is shrinking, and the ventricles in yellow are expanding. So we now can really map how the brain is changing. And that's important because if we can intervene with a therapy, i.e. switching off the mutant gene, for example, with gene silencing, we can very carefully map and see how that process is affected. So this is important in terms of moving forward. And you can see here, we really can we've got a really good understanding of how the brain changes. We've also found a number of changes, as I mentioned, in non-imaging measures in pre-manifest HD. This is a tapping task developed by Ralph Rallman, and this is an example. The individuals have to tap on a force transducer, and in early stage HD and in the pre-B group, significant changes in tapping compared to controls over 36 months, but not in pre-A. Again, this is tongue force. So the subjects have to press their tongue for a sustained amount of time against a force transducer. And it's measured very, very carefully with different levels of force transduction. And here, again, we can see changes in the pre-B group. And this is a very subtle way of looking at the motor function of the tongue. And this is a lifting task, which you do with your left hand, if it's your non-dominant hand. If you're right-handed, and again, we found significant changes in pre-B compared to controls doing this task, but not the pre-A. We also found many significant changes in neuropsychiatry over 36 months in pre-manifest HD, and this is the first time we've really found such changes, and the reason for that is, luckily, and as David discussed, and this is very important in clinical practice, many of the neuropsychiatric symptoms such as depression and anxiety and irritability, we can treat with conventional antidepressant medication, for example, and we can treat it effectively. So all the people in TRACK-HD were treated accordingly. However, there are some neuropsychiatric symptoms that are not amenable to treatment, or not particularly amenable to treatment, and this is apathy, and also this is the overall psychiatric score. And over 3 years, we found changes in pre-B and stage 1 in apathy scores. And this is telling us that something is happening in the pre-manifest phase of the disease in terms of apathy, even before symptom onset. So just in the final few slides, the conclusions from the 36-month data is that we have many changes now in non-imaging measures, which are potential outcomes for clinical trials. Pre-A group, 36 months is still not long enough to detect any deterioration in non-imaging measures. And I think the data suggests that if you're greater than 10.8 years to predicted onset, the disease is still progressing so slowly that its clinical trials at that group at this stage are probably not going to happen at this stage. It's the pre-B group that are the likely candidates for pre-manifest trials in the future. We're also trying to understand what defines at baseline whether you progress. So we look at baseline stratifiers and try and say, based on what a person looked like at baseline, can we make inferences about the way they're going to progress? And we really want to try and understand what determines progression, including modifiers of progression, moving forward. So this is a timescale for volumetric changes of the brain that this is based on data. So the group that we have, the furthest from onset is 16 years to predicted onset. That group, in terms of their caudate volume, it's never the same as a control group. But this is how the caudate is changing over time based on the TRACK-HD data. And this is compared as a percent of controls. This is grey matter and white matter, clearly progressing more slowly. And we really now can begin to map how the brain is changing. But you can see here, the grey and white matter compared to controls at terms at the beginning of the disease in those 15 years from onset is very similar. And so we're really trying to map the neurodegenerative process. And the reason we need to do this is we need to understand the preclinical phase of neurodegeneration and the early phase, because we haven't had good measures or really had a good handle on this. We know that the striatal loss begins about 20 years before your predicted onset. The slow cortical loss begins about 10 years before onset. And there's striking progressive white matter loss from this stage. There is subtle thinking and motor dysfunction about 10 years before onset. And there's a long psychiatric prodrome, which understanding the biological basis of that, which may be additional genetic factors, is a subject of ongoing work. So just to finish, we do have challenges. Despite striking brain changes, the pre-manifest HG gene carriers, which if you remember that data, over 24 months did not deteriorate. Despite those changes I showed you in the brain, over 24 months they performed as well as controls on tasks of thinking, difficult tasks of thinking, motor tasks, and a number of other tasks. The pre-A group did not deteriorate compared to controls over 36 months. And that tells us that the very good news is, despite those brain changes that I showed you, there is a lot to rescue. Nerve cells are compensating for the effects of the mutant protein because we're not detecting over that time period deterioration compared to a control group. And that tells us there must be a compensatory network. The nerve cells must compensate, and that's what we need to try and disentangle for therapies. And what we think symptom onset is that we think that is a decompensation of compensatory neural networks, and that the brain compensates and compensates and compensates, and that symptom onset is a decompensation. And our data in TRACK-HD is very supportive of that hypothesis. So, and this is, promise, the final few slides. I'm just going to tell you how we're going to interrogate that. And this is a new study called TRACK-on-HD, which is just in the pre-manifest cohort. And the hypothesis that we're going to test is that there is a functional reorganization of networks that precedes the widespread structural loss, and that there is a compensatory functional neural network that exists in the pre-manifest phase of neurodegeneration, and that that decompensates prior to symptom onset. And it's trying to understand this is going to be critical because we may be able to intervene with therapies that maintain that compensatory network. And we have some data supporting this hypothesis. This is a paper we just published in Brain, and this is a cohort of pre-manifest HD gene carriers doing an emotion recognition task. We know that if you do the emotion recognition task in people who carry the gene but don't have symptoms, they don't perform the same as controls. They have a different way of recognizing emotions, and many of you will know that from your clinical practice and looking after patients with HD. So what we found, though, on this task, in the group that we studied, they performed just as well as controls on emotion recognition. In the cohort that we studied, who were within 12 to 15 years of onset, performed just as well as controls on this task. But they activated a completely different part of their brain to be able to compensate. So what we found is they activated a number of extrastriatal pathways that allowed them to perform as well as the controls on this cognitive task, and the control subjects did not activate those regions. So it was all a number of extrastriatal regions. And what this tells us is that we've done a similar study with tapping, where an extrastriatal network was activated in tapping when subjects performed as well as controls. So this tells us that the pre-manifest gene carriers are activating a compensatory network in order to be able to perform the task as well as controls. And this is data supporting that. So this whole study is moving forward to take these small observations into a much bigger investigation. And what we're going to do is recalibrate the sensitivity of the TRACK-HD assessments. We're going to use functional measures of functional MRI, which is measuring what we call bold signal, which is really a measure of, no one really knows what bold signal is, but it's probably a measure of oxygenation. We're also going to do transcranial magnetic stimulation, which is a way of looking at the motor cortex functionally. And we're going to see the functional relevance and biological relevance of our structural imaging. And I hope that this will help us understand the pathophysiology of HD. I hope it'll help us understand the neural compensatory network, because I think once we understand that, I do think we'll be ready to do clinical trials in the future in people who carry the gene but don't have symptoms. Going back to my original schematic, in that I do think over the next 10 years, we're moving into a very exciting phase of finding treatments for HD. So this is the Track HD team at the training meeting. This is the thanks for everyone. We did this, I originally presented this talk during the Oscar week. And Ed Wilde changed my acknowledgements without telling me and made it look like a film. So these are all the people who contribute to Track HD. And it's been a huge team. We work very well, and they've been amazing, and we continue to work. And this is some of my team, many of who are here, who do a lot of the hard work. This does need updating. And thank you very much for your attention, for listening, and I'd be very happy to answer any questions in the coffee break.